Hello, this is Michael Altos, and we are finishing our discussion of herbal medications and dietary supplements. This is recording part 3. Marijuana has become a significant issue to deal with in our patient populations due to increased use both medicinally and recreationally. The active chemical in marijuana is THC, which stands for delta-9 tetrahydrocannabinol. There is a second chemical called cannabidiol, which you may see advertised as CBD, and this substance actually lacks many of the psychoactive effects of THC, and its effects on anesthesia are unclear. It may even antagonize the effects of THC. But today's discussion will be limited to THC itself and the use of marijuana for its psychoactive purposes. The pharmacology of THC starts with noting that it is a partial agonist on the cannabinoid receptors, which are located primarily in CNS tissue. When THC binds to these receptors, it inhibits the release of acetylcholine, glutamate, GABA, norepinephrine, dopamine, and serotonin, among other neurotransmitters. If marijuana is ingested by smoking or inhalation, the onset of action is very short, on the order of seconds to minutes, with a maximum effect after about 15 to 30 minutes and tapering off after 2 to 3 hours for a total duration of about 4 hours. And the effects that we see mirror the plasma concentrations of THC. If the drug is ingested orally, the onset is much slower, of about 60 to 120 minutes, with a peak right there at 120 minutes and lasting 4 to 6 hours. THC is very lipophilic, and it is metabolized in the liver by the P450 system. As a result, chronic use of THC could increase the effect of other drugs metabolized by the same subfamily, and those drugs might include warfarin, and it may decrease the effect of theophylline. THC could have an additive pharmacodynamic effect with other CNS depressant drugs, which includes benzodiazepines, opioids, and volatile agents. So the acute effects of marijuana include tachycardia, vasodilation, and orthostasis, and notably an elevated risk of MI within 1 hour of ingestion of THC. And this is in the perioperative period, especially something to keep in mind, a 5-fold elevated risk of MI within an hour of using marijuana. In the pulmonary system, we expect there to be bronchospasm and airway hyperreactivity associated primarily with the inhalational route of administration. In the GI system, it is anti-nausea and increases appetite, and may also precipitate abdominal pain. In the CNS, we see a variety of effects, including anxiety or anxiolysis, paranoia and psychosis, euphoria, dizziness or headache, analgesia, and, again notable to us, violent emergence from anesthesia is possible. People who use marijuana chronically are more likely to develop cough or bronchitis and emphysema, and may develop CNS tolerance to the effects of the drugs, and therefore possible increased anesthetic requirement for both induction and maintenance dosing, as well as an increased analgesic requirement. Also note that chronic marijuana use has been well described to cause hyperemesis in a subpopulation of users. There is a withdrawal phenomenon seen with marijuana, cessation of marijuana use. Patients may develop irritability, anxiety, depression, or insomnia, anorexia and abdominal cramping, headaches and tremors, and the onset is usually within a day for people who are high-dose chronic users. The duration of the withdrawal syndrome may be up to several weeks. So let's focus on the perioperative period. When patients tell us that they use marijuana, we want to clarify their history, including how often they use it, how long they've been using, and when their last use was. It's a good time to assess for other drugs that may be used in the patient's personal social practice, or for other drugs that may be mixed into the marijuana, depending on where they obtain their drugs from. Tolerance to induction agents and requiring higher induction dose is something we need to be on the lookout for. We really can't predict what their tolerance will be to other anesthetic agents, and so we have to make some clinical decisions as we care for our patients. Studies have shown elevated BIS in patients with history of marijuana use, and that may suggest that we have to adjust our anesthetic dose accordingly. Again, be aware of the increased risk of postoperative MI, especially in patients who have currently or very recently used marijuana. We're watching for airway hyperactivity. And we definitely want to be ready for heightened pain perception and a possible tolerance to opioids. Patients may have post-op shivering and hypothermia, and again, in chronic, long-time users, heavy users, be aware of the possibility for withdrawal. That wraps up this section. As always, be in touch with any questions, and we'll look forward to seeing you in class.